should only have one today, so it should be quick. This is a 68-year-old patient, and she has a history of multiple myeloma. She had a stem cell transplant a year ago, about a year ago, last June. And on follow-up scans, she developed all of these. So these are the follow-up scans. It's here, yeah. So the scan on the right is from February. She had some more scans, but I'm only showing 2 of them. The scan on the right is from February, and then the one on the left is a more recent one from May. But she has all these scattered nodules, and they're very upper lobe predominant, very well circumscribed. So it's somebody with on immunosuppression with a stem cell. So differential consideration here is the main thing is infection, and so these were thought to be granulomas, but and they're stable over a long period of time. All the workup was negative for infection though, and she ended up here on the scan on the left. You can see that she had a biopsy, and I'll show the path. That's kind of interesting. So this is a rather common thing, but an atypical presentation. So so it is so there are granulomas. You can see it on the low power. You can see the granulomas are necrotizing granulomas, and that's how they were first. This pathology was first at an outside hospital. And they just basically saw it as granulomas, and then it was sent to our lung pathologist. He took another look at it, and so this is a higher power view of the granuloma, and then these are GMS stains for fungus. And so our pathologist on a higher magnification was able to see these little oval cyst-like things here deep buried in the granulomas. So those are pneumocystis, these little helmet-like or oval-shaped cysts with a little dot in them. So here's the report. So pneumocystis within occasional granulomas. This is basically a abnormal presentation of pneumocystis with granulomas.
Oh, wow, I've never seen that before.
Wow.
Yeah, I hadn't either, and I hadn't really heard much about it. But then there's plenty of papers and stuff like that written in the literature about it.
So did the granulomas look like that because they were necrotic in the middle? They weren't very cellular.
No, yeah, they were necrotic. Yeah, let me pull that back up. Yeah, so this is necrosis in the middle.
David, have you ever seen pneumocystis look like this?
No. This is a new one.
I can send out the literature, but yeah, so
cool.
And then yeah, I read about it, and basically, as you guys know, the main is the ground glass, which is just exudate. The main presentation is just the ground glass with the exudative foam casts in the alveolar spaces, and then granulomas are like way down the list of presentations. You could get DAD, and which you guys have probably seen from pneumocystis, but yeah, granulomas is also one of the presentations.
I wonder if it reflects the abnormal immune status of this person having somebody else's, marrow on board and stuff like that. Maybe
that's a good thought.
By that.
Yeah. Okay.
All right. Thanks, Peter.
Thanks.
All right, Travis.
All right. I know it's been a while.
Travis,
been a crazy couple of months.
Blue Devils.
What's that?
Go Blue Devils.
Yeah, 2 weeks I'm moving. So.
Okay.
Yeah, so this will be a few of the last cases I show from UCSF, but we're gonna try and recruit one of my fellows who's staying on faculty to help out and continue to show stuff from here once I've moved on. So these are some interesting ones. This is one that my colleague Eugen showed me And this is a patient who was undergoing preoperative planning for, I don't remember at this point which valve it was, but you can see they've had prior prosthetic tricuspid valves and mitral valves. And the tricuspid valve is the valve of interest. She had had her original surgery in the 80s, had endocarditis within the last decade, had it replaced again, and we'll continue on that. I'll give you some more information here in a moment, but this is the recent CT, and she showed me this and said, well, this looks kind of funny. And it's a transcatheter valve, and it's, as you can see, it's kind of lodged in the ostium of the coronary sinus, which is peculiar. And so we went looking at radiographs, and you can see this was a few months before that. And sure enough, it does look like a transcatheter valve. And I think this case really underscores the value of not just looking at the immediate prior radiograph, but looking at all priors. And I was certainly guilty on one of these. It may have been this one in November, or one of these earlier on in 2019. We can see it's here. But the question is, why the heck is it there? And we go back even further, and in 2015, you'll see there is no transcatheter or transcatheter valve prosthesis there. And in, I guess I don't have the other radiograph, but in 2015, she had an interval procedure, which was transcatheter placement of the valve in the tricuspid position to treat recurrent tricuspid regurgitation. So sometime between 2015, and you can see there's nothing in the coronary sinus, sometime between 2015 and 2018 or 2019, this thing actually dislodged and somehow made its way and got stuck in the ostium of the coronary sinus, and sat there for years. And the funny thing was, she had had 5 or 6 radiographs, she had had a dozen echoes, and nobody had ever commented on this, the change in position of this. And it was funny because after this thing embolized, they reported that her tricuspid regurgitation was still improved compared to prior. So this was clearly a surprise to the surgeon, as it was to all of us. And they were able to do a minimally invasive approach through the right hemithorax, take that thing out, and then they placed a larger valve within the tricuspid prosthesis. So redo valve and valve. So yeah, I've never seen anything get lodged right there like this, but it was in that position unchanged for several years.
Travis, anybody figure out why it went retrograde? And I mean, there was regurgitation, but why it would lodge in the coronary sinus? You'd think it would just float in the right atrium or something.
Yeah, no idea. And I don't even know what direction these valve leaflets are pointed, because that was actually one question, because there was, was this just even further creating stasis? Because this was a study on, as you can see near the end of April, where I think this was probably some laminar thrombus, or thought it was, because of the fact that if it's contrast, it should be denser than the blood and pooling. But this looked like, and this was actually fixed on 2 different studies. So that was the gated study, and then this is the follow-up abdomen and pelvis that's done immediately after that. But then a week later, I don't know, if I haven't checked to see if she was anticoagulated or not, but a week later, that's all gone. But yeah, I have no idea, Jeff, why it went there, but that's where it stuck. But yeah, just looking at the immediate prior radiograph on all of these, it was correct to say there was no change in the position of the prostheses. Nobody had actually recognized that it was in an inappropriate position.
So Travis, did the radioatrial enlargement increase after that valve dropped out of position, or was it the same huge right atrial?
I think it was always, this is back in 2012, pre-everything. And I don't think you can say that there was really any substantial change.
Okay.
Now this one, I'm curious about terminology as much as anything else. And this is, in the era of COVID and of lung injury, having appropriate terminology for lung injury, I think, is important. And so I'm curious what everyone thinks. This is not COVID. This is a woman who is immediately post-op from cervical spine fusion, and she had had a remote or subacute cervical spine fracture. So I don't think this is neurogenic edema, but you'll see over the course of 2 days, she fluffs out with bilateral, symmetric, predominantly perihilar opacities. Her heart is normal. I'll show you the CT. They're kind of coarse. It's not really super fluffy like we typically think of with alveolar edema. It doesn't look like there are effusions here. But you'll see that this kind of persists, and she's not actually that symptomatic, but she is hypoxemic. So she is requiring several liters at rest. She never is intubated and never clinically diagnosed with ARDS, but did a CT PE study that you'll see here. And this is what it looks like. And this is, keep in mind, 3 days after a completely normal radiograph. So crazy paving appearance, a little bit of peribronchial cuffing. And so I thought this was edema, and given the absence of effusions, the normal heart, I thought maybe this is just the permeability edema rather than hydrostatic edema. And of course, knowing that, just being in a post-operative state, surgery can cause edema. If she gets better over the course of like 4 days, at baseline, they did a follow-up CT, and so this is 4 days after that other CT. And you can see now, I think that there's some airways that are a little bit dilated here. So I'm curious what you guys think, because my whole theory on this is just permeability edema without diffuse alveolar damage that improved fairly rapidly. And at this point, you have an organizing phase of lung injury. And I'm curious, how you would phrase this, because her entire workup for infection, her cardiac workup was all negative. It wasn't hemoptysis or hemorrhage. So
what did they do to her cervical spine?
they did some sort of fusion. It was I don't know, it was a discectomy and fusion.
I think this is fat embolization.
She wasn't really that symptomatic though. Have you ever seen fat embolization this like diffuse? And usually those patients are very symptomatic in my experience.
Agreed.
Was she hypoxemic?
She was requiring several liters of oxygen, but she wasn't actually describing dyspnea. It was more just they saw that she was hypoxemic. And I was looking at this because there was an extensive pulmonary consult.
Negative pressure edema, maybe after the intubation.
Well, as a form of permeability
I think
edema.
it's also permeability.
Yeah.
A form of permeability edema.
Well, I think there's a spectrum of fat embolization, and it's, the cases that are brought to attention are the severe cases. So those are the ones that form your baseline in your expectations. But I've seen a lot of people who've had orthopedic surgery who have what is probably, have varying degrees of fat embolization. They get diffuse lung disease, they're hypoxemic a little bit. They're often better in a couple of days. It's not always there on the first post-operative radiograph. So the time course that you're showing here is just fine for that. So I really think there's a spectrum. And, this does not look like edema to me. I think this is lung injury. There are not that many septal lines. There's a little bit of, the fissure is kind of fat, so that goes along with edema, but there are actually very few septal lines in this thing.
But if we say permeability edema as a form of lung injury,
well,
I don't think it's hydrostatic edema.
Yeah, right. So it's, it's not watery edema,
right?
Because there's just not that much septal line. So, so there's some stuff besides water getting out of the capillaries. So that implies that there's some degree of injury of the barrier. So I think, I've seen this. I've seen a number of cases with after orthopedic surgery, particularly when they when they put pedicle screws in up and down, when they do extensive spine surgery and they're drilling and they're screwing into marrow, you're mobilizing a lot of stuff into the bloodstream from the marrow. So I think all you have to do is put a screw into a vertebral body, and you're going to release marrow in fat into the circulation.
But even symptomatic cases of fat emboli, I've never seen lung disease this diffuse, because usually it's more nodular and it's often more peripheral without these areas of subpleural sparing or subpleural clearing. That's the one thing I can't.
I'll go back to cases that I showed a couple of years ago. I think I had some that were pretty extensive like this.
And I also just assume that the orthopods run the fluids in at a liter an hour, and those patients always get blooded. But
this doesn't look like edema, though. This doesn't look like water. Yeah.
No, it's not watery edema. I think we all agree it's not congestive or hydrostatic edema. But that's why,
And the other thing, Travis, is the orthopods are always in denial about this. You bring it up with them, they will just swear up one side and down the other, and they just resist the idea. So it's really underreported. I think radiologists see it more often than the orthopedists, register it. So, yeah. Well, I'll try to pull my cases. I think I had something on this order.
Okay. Yeah, because
I was
she
just gonna
doesn't
say-
have any. Oh, go, Jeff.
Sorry, I was just saying, I wish, this is Misha from UCSD. I wish Seth were here
Okay.
to weigh in. I feel like he would probably just, based on my experience with him, I feel like he would lean toward edema on this just because the degree of airway dilation is, they may be mildly dilated. I find this really hard to tell sometimes with the ground glass, but I just think he wouldn't be impressed enough with the airway dilation to call this organizing lung injury. But I think it's tricky.
Yeah, at this time, I think you do have some mildly dilated. It looks like you're starting to get a little bit of like distortion in some of these areas and a little bit of perilobular stuff like you'd see with organization at this point. But I agree, it's mild, but she's also getting better rapidly.
It takes a while to get organized. It takes me a long time. So I think organizing stuff, maybe Seth is thinking of something over a week or 10 days, but this is a much shorter time course. I don't think there's that much organization in this.
Yeah, on this one, we're at that 7-day. Yeah, we're at that 1 week, but yeah, I don't know. It's just, that's why I'm just curious what you thought. And anyway, I think we all agree it's not hydrostatic edema.
Can you put them side by side, Travis? Do you think the veins are a little bit more plump on the like the peripheral?
On the earlier one?
On the acute one.
Yeah.
Compared to the
They might
airway.
be,
So it seems like
yeah, they might. That's a good point too. So, I mean, they diurese her as well, but I don't think any of us think that most of this is due to hydrostatic edema. But all right, well, I'll see if I can dig up more information. And David, I'd like to see those other cases.
Okay, I'll only show them if they concur with one of my assertions today. So if you don't hear from me, I back down.
This is quite an interesting one, and this was a really good observation by one of our residents on call. You can see this is only over the course of 10 days or so. And this patient, the earlier one, I think there's an abnormality here. This was from the general that this was called normal at this time. He had chest pain. And you can see that the resident at this point realized that 10 days later that there was something going on in the mediastinum and correctly recognized this had to do with the aorta. You can see that there's increased depression of the left mainstem bronchus. The aortic arch here, there's just more stuff in between, and it seems to be widening out as well peripherally, not to mention that there's a little bit of mass effect and increased deviation of the trachea. And so they raised the possibility of some sort of acute aortic process. This patient had ongoing chest pain, and so they did go to CT. And you will see here, this is at the same time as that radiograph, and this patient has a large pseudoaneurysm in the region of the isthmus here. And this is one where they thought maybe it was due to a penetrating atherosclerotic ulcer. I wonder if this could be a mycotic pseudoaneurysm if the patient was infected. Either way, they did stent it. I don't know if he had signs or symptoms of infection because this never got transferred to us. But I thought this was just a really good radiograph, just showing, can be subtle when you have aortic abnormalities, but just all of the different findings that contribute to this appearance in this case. And I don't have any of the post-op imaging, but I don't know. What do you guys think? Infection, PAU?
And tough to tell.
If it's infection, they probably wouldn't want to put a stent in there, right?
No, that's not necessarily the case. We've seen several known to be infected where, at least with antibiotic therapy, they weren't going to operate on and they've placed stents in. I agree. You would think they wouldn't want to, but we have seen it done. So, but yeah, and regardless of the cause, I thought it's just a good illustration of subtle findings on a radiograph and how they can evolve relatively quickly into not so subtle findings once you know what to look for. All right, and then I will show one more. This is a fun radiograph. If anybody wants to comment on what they see here.
There's something left to the aortic arch.
Yeah, same area, right? You've got
Yeah.
kind of
There's an extra.
indistinct aortic arch.
Yeah, there's that
Yeah.
vertical
And then,
interface there.
yeah, exactly. And so I saw this, and I don't even know what this was being done for. Actually, this is the more recent one that I saw, but this was something known. And you can see there's just an indistinct aortic arch. There's this extra diagonal interface here. Wondered if it could be a vertical vein or like from an anomalous pulmonary vein. Don't really see much of an AP window here, but Jeff, you'll like this one. You'll see that this is a left superior vena cava. There's also a right superior vena cava, and it does drain into the right atrium via the coronary sinus. But the interesting thing is this, and this represents hemiazygous continuation of the IVC all the way that drains up and drains into the left SVC via the superior intercostal vein. And then this patient also has some sort of heterotaxy. You can see their liver is more midline. They have spleen, stomach on the right. But then you look at the airways, and it still looks like there's normal airway branching pattern, that you have a normal right lung, right upper lobe, bronchus intermedius, and a normal left lung. So it's just one of these strange heterotaxies, but I thought it was just interesting with this type of vascular branching pattern, or this vascular development or abnormality.
Yeah, I like hemiazygous continuation of the IVC. That's great.
Yeah. So, all right, those are mine.
All right, cool. All right, I pulled up some of my fat embolism syndrome. So here's one. Now this was a younger patient who had I can show you a long bone fracture there. And this happened post-op. You can see there's this, became short of breath and this diffuse opacity, but this was the CT that was done shortly after. And it's not as extensive as your case, Travis, but it's still a lot of this kind of ground glass, more nodular appearance, but within the nodules, it looks sort of crazy paving-ish, but not a lot of septal thickening, but a fair amount of lung involvement in that peripheral sparing. So, and this patient happened like within hours after the OR when they put a rod through the tibia there. And then this case is another patient who had another bunch of long bone fractures, became short of breath afterwards on CT. You can see almost looks like organizing pneumonia like with atolls and stuff, but that crazy paving texture is there, and it's almost as extensive as your case. So maybe I think David may be right that you can see this extent. I've not seen it with spine. I've not seen it with cervical spine though. I've only seen it with long bones.
Both of your cases are much more, they're diffuse, but they're still more nodular
True.
Yeah.
But we may never know because it's getting better.
Yeah, right, exactly.
Because
No, those are
I would
nice.
expect I mean, if it was an organ, I mean, I wouldn't call it organizing lung injury in the sense of organizing pneumonia because that takes too long to go away. I agree it's some sort of non-cardiogenic edema, what the cause is, but fat embolism might be a good cause because it'd be something that would come and go rather quickly and can respond with just oxygen.
That's actually a good point, right? That could be the unifying diagnosis that the fat embolism is causing a form of lung injury.
Yeah. Anyway, cool. All right. Well, I'll start with a congenital case. This is a 70-something-year-old, and I forgot what the CT was done for, but had some interesting anatomy. So already you'll notice the left hemithorax looks smaller, the left lung is smaller, and maybe a little more lucent. So first thing you notice is there's a tracheal bronchus here, and maybe even I can't tell if that's just a little fold of tissue, if there's an attempt at a branch there. And that goes, of course, to the upper portion of the right upper lobe. And then you come down here to the carina, and you see you're missing, well, where's the right upper lobe bronchus? We should see it already, but we don't. So we get into what looks like bronchus intermedius, and then there's the kind of a low takeoff of a right upper lobe bronchus, but you'll see it only bifurcates, and the anterior segment is there, and I guess this is a posterior segment. They're fairly small. And then there's the short bronchus intermedius with a middle lobe bronchus, 2 segments, and then the right lower lobe looks fairly normal, other than you have a dual branch and then a small medial basal segment. But you'll see the oblique fissure is normal, but there is no horizontal fissure at all. So you have a bilobed right lung, although it has, I would say, it's normal size, but there's a weird branching to the right upper lobe. And then you come to the left lung, which is already small, and you see the left main bronchus is narrow. There's some secretions in there. And there's the upper lobe branch, but you don't see a lower lobe branch. So just sort of this, or I should say a left lobe. I'm not sure if it's an upper or lower, but it's got funny branching. So then we want to look at the pulmonary veins, and you can see there's a right inferior pulmonary vein, an accessory branch, and there's a superior branch coming in. On the left, there's just this one vein branch coming in there. It looks like it's an inferior branch, so maybe this is just a lower lobe. But it's sort of a common trunk because there's this superior vein that comes into there, but it all inserts at the typical location. So just an instantly detected weird anomalous lobation of both lungs. I looked carefully for the vascular anomaly, but it wasn't there. So nothing there, no anomalous vessels in that department, but just a kind of a fun congenital case that clearly escaped detection for 3/4 of a century.
So, Jeff,
yes.
do you think there is a right upper lobe, but it's scrawny?
Yeah. Well, it's let me show you the coronal. It's fused with the middle lobe. So if you look, there's only 2 lobes to the right lung, but there's a tracheal bronchus supplying a big chunk of it, and then there's this sort of wimpy upper lobe bronchus coming off here, and then a middle lobe bronchus down here. But there's no separation between the 2.
Got it.
So I would say the anterior and posterior right upper lobe are supplied off the bronchus intermedius, if you want to call that this, because the right main bronchus is virtually non-existent, and then the apical portion is supplied by this large tracheal bronchus, and then you can see the left branch is just this little tiny thing.
It seems that when there is a tracheal bronchus, the remainder of the right upper lobe bronchus is often lower than usual, which means there's a longer main main bronchus before you get the right upper lobe takeoff. So it's often displaced downward. If you average the position of the tracheal bronchus and this downward displacing, you'd come out to the normal height. So or the normal level of takeoff. So this is lower than I've ever seen before.
Yeah,
So,
I mean, there it is right there. There's the middle lobe and there's the lower lobe.
Got it.
Okay. Yeah, it was kind of cool. So this is something I remember. I have not seen one of these in a long time. So this patient was, let me show the esophagram first, was referred for, had some swallowing issues. And you can see on this esophagram, there's this outpouching that's fixed in the mid esophagus. You can see it doesn't empty. Decent motility, but not, she had some motility issues. Let me show just another view there, just showing you that right there. So you descend the esophagus, and then you can see there's clearly communication there. So it's a diverticulum, and typically in this area, it's classic for a traction diverticulum. Usually the pulsion diverticula are down low and up high. And classically, this is the result of TB. But of course, I live in the Midwest, and while we have TB, we have much more histoplasmosis. And there's this little diverticulum here. It's not distended on this scan, but you can see it sitting right next to the subcarinal node that has a big chunk of calcium in it. And there's calcifications in the hilar nodes. And I know David's going to ask me, so there's the splenic calcification. So this is not TB, this is histo. But this is a traction diverticulum from histoplasmosis. Little guy, but yeah, I have not seen a traction diverticulum in a long time. So actually, honestly, the esophagram is more helpful, but the CT shows the relationship to this calcified lymph node. And a lot of times these are pretty hard, and if there was inflammation, sometimes they can be stuck. So resecting this can be challenging and may require thoracotomy. This is just something we don't see a lot. I came across the follow-up on this patient recently. So this is patient presented back when with actually hemoptysis, and on this portable radiograph had these huge masses in both lungs. Young guy, so you got to think of things like testicular tumors, sarcomas, and such. He ended up being diagnosed with a testicular mixed germ cell tumor that had embryonal components, so very aggressive. Here is the CT done at that time, and you can just see the size of these. He had lymph node metastases. These are the so-called cannonball metastases that I think residents and medical students learn about early on, but probably never see very often. But this is a nice example of that at that time. But they often respond pretty well to treatment. Now, this is something kind of cool, and I can't prove the diagnosis, but I can prove the diagnosis, I can't prove the cause. So this was a 19-year-old who developed shortness of breath and chest pain several days after his second dose of an mRNA COVID vaccine, and was seen in the emergency department and had elevated troponins and his EKG changes. And so he had an echocardiogram that showed some LV dysfunction. So they got a cardiac MRI, and let me see if I can find all the series I want to show you. Yes, so here's the cine of the short axis, and you'll see there is hypokinesia of the left ventricle throughout. So his EF is actually about 30%. So 19 years old, previously healthy. Here's a cine of the vertical axis, and again, you can see that global hypokinesis. On the, let's see, where's the T2 images? Oh, I never can find anything. Yeah, here's the T2 map. And we can see there is some edema in the myocardium. It doesn't show all that well, but there's a little bit, you see some edema in the myocardium. But I think the post-gadolinium images, and I'll find them, show it best. Right here. Yeah, so you can see the late gadolinium enhancement in the mid-myocardium here, the LV. We see it in a couple images. Yeah, I see it's kind of patchy there through there. So it fits with a myopericarditis. And you may have read that the CDC has been there have been a few reports of myocarditis developing in people several days after one of the mRNA vaccines. So the timing is the only thing we have in this one. I'm being treated with medical management and should hopefully make a full recovery. But just something to be aware of. It's kind of getting to summertime, so that's a time when some of the viral myocarditis shows up. It's usually later summer, but whether this is caused by something else. But I don't know if any of you have come across this or heard of cases.
We just had one this week, and it was not nearly as like flagrant on the MRI, but clinically they had a diagnosis of myocarditis. They had recently had the vaccine. I know there was one case at Mallinckrodt a few months ago, early on in the vaccine period.
Yeah.
But this is the best example I've seen. And your point is, like, when you give millions of people vaccines, some people are going to get myocarditis. So is it related or not? I don't know.
Yeah, it's just the
Jeff,
timing. There's been enough cases with the timing
Right.
shortly thereafter.
any, I don't know if you know this, but was there anything on the drug tox screen?
My
Positive?
understanding, it was all clear.
Okay. So we just had recently, we had I think it was a 18 or 19-year-old, very similar myocarditis, and she, the only thing we could tie it to is she was positive for marijuana, and then some reports of abnormal substances from the marijuana causing it. But I don't think this was before the COVID vaccine, so I don't think she was vaccinated.
It doesn't surprise me because, of course, there were those studies of the athletes here at Wisconsin, but also at Ohio State, where they found myocarditis in a small. I mean, we had 2 patients out of like 100 or however many hundred that had findings. They all had COVID, so I suspect there's some cross reactivity maybe with the antibodies because it didn't really correlate to the severity of their illness, and they were recovering from COVID. So it may be some cross reactivity with antibodies with the myocardium or some kind of inflammatory response as opposed to the virus itself. I don't think we know the answer to that, but that would make sense why you would see it also in a very small number of people getting the vaccine because it's quite an impressive immune response and it's targeted to that spike protein.
Yeah.
Because I think I can't remember this is one of the mRNA vaccines. That's all I know. I don't know which one it was, and I think there've been reports with different ones, but I don't think it's been reported with the AstraZeneca and the other vaccines. So the AstraZeneca, I think, is an adenovirus. One of them is a adenovirus, and one of them is it's another kind. Yeah, they use other viruses as opposed to the mRNA technique, and so those are the ones that were associated more with the blood clots. Okay, well, that is all I have, but good cases this week, and yeah, I'll talk to everyone next week.
Sounds good.
Yeah.
See you guys next week.
Bye, everybody.
Bye.